Afternoon, everyone. Hello, welcome. Thank you so much for joining the Alumni Association of the City College of New York for the importance of mindful transitions into adolescence and adulthood with Dr. Mira Beharin. My name is David Covington, and I have the honor of serving as the Executive Director for the Alumni Association of CCNY. For those of you who may not be familiar, the Alumni Association is a 169-year-old membership-based independent organization operating on the campus of City College. It was founded by the first graduating class in 1853. And with their original interest in mind, we seek to establish beneficial relationships between the City College and its alumni, while supporting and promoting meaningful connections among alumni, students, faculty, and staff. And one of the ways we do this is through hosting engaging events like this event today with esteemed alumni such as Dr. Beharin. Our presenter today, Dr. Beharin, is board certified in both pediatrics and adolescent medicine. She was born in the Caribbean and grew up in the suburbs of New York City. She attended the Sophie Davis School of Biomedical Education at City College, which is now the CUNY School of Medicine at City College. Dr. Beharin completed medical school in 2001 at SUNY Downstate, where she stayed on to complete her pediatric residency, including a year as fourth-year chief resident at Lenox Hill Hospital in 2005. She went on to complete a 3-year adolescent medicine fellowship at Children's Hospital of Los Angeles. After completing her fellowship, Dr. Beharin returned to New York for a faculty position in the Department of Adolescent Medicine at the University of Rochester. And in 2021, Dr. Beharin started her own consulting firm and concierge consulting private practice with the goals of improving access to medical care for adolescents and young adults experiencing a variety of health issues. You can learn more about her and her private practice at pediatrics.com. So we're so pleased to welcome you, Dr. Beharin, and thank you so much for being with us today, and no less during an appropriate week. Is it right to say Happy International Adolescent Health Week?
Yes, thank you. Happy International Adolescent Health Week to you too, David. I am really glad that we were able to work out the timing for this topic and to celebrate young people in general. For those of you who are interested in learning more about International Adolescent Health Week, I will have some information about how you can join that movement and spread the word about adolescent health. So for today, I did put together a formal presentation just to help guide some thoughts and discussion, but I would love for us to have some free time to just talk about transition issues and adolescent health issues in general. So without further ado, I'm going to pop on to my slides. And David, can you confirm that they are displaying well?
Yes, we can see them.
Fabulous, thank you. So today's topic, the importance of mindful transitions into adolescence and adulthood. Goals for today would be to discuss typical transitions that occur during adolescence and into adulthood, as well as reviewing some challenges for youth with special health care needs, and then a discussion about how adolescent medicine specialists can help. As I mentioned, it's International Adolescent Health Week. The International Adolescent Health Week movement started as Teen Health Week in Philadelphia and then has spread to around the world. Literally, there are celebrations and different events happening everywhere. Some communities have actually done lightings of large buildings and group yoga, all sorts of wonderful things. So I encourage folks to check out some of the offerings, as well as hopefully learn more about adolescent health in general and get some of the young people involved, because we know having positive connections to community helps young people grow into happy, healthy, productive adults. I like for us to start our discussion on adolescent health by thinking about our own lives and reflecting on where we were when we were 18. For some people on this session, that might be now. You might actually be 18. For some, that might be ahead or quite a while away. What were you hoping for? What did you focus on during that time? What was your day like? What was your primary focus? Um, David and I had a chance to chat a little bit before the session. And when I was 18 and just starting out in the Sophie Davis program, it was hard to believe that I would be at a place where I would have my own practice, have some academic affiliations, have participated in some of the wonderful organizations that I've had a chance to work with. My focus was getting through organic chemistry and making sure that I did everything I needed to do and walking up that hill to campus. So thinking back further, what was it like when you were 16? How stressed were you? Who were your supports? What did you wear? What did you listen to? And then going back further, 13. What was your primary focus at that phase? For most young people, it is more about what's changing in their lives and their bodies than it is about the larger things that are going on in our world. And then going back to 11 and even younger. So I want you to just keep those different aspects of yourself in mind as we talk about adolescent health in general, and hopefully stay in that place when you interact with younger people in your day-to-day life. Adolescence is defined as the transition from child to adult, and this occurs in a few domains. There's the physical maturation known as puberty, where the person develops their secondary sex characteristics and becomes physically capable of reproduction. There's a social maturation, changing from one who is cared for, a child, to one who should be able to care for themselves and hopefully contribute to society. And ideally, an emotional maturation. We expect toddlers to have temper tantrums. We don't expect that from our teenagers. Personally, I like the biopsychosocial model, and I feel like it melds very well with adolescent medicine because of those different domains of maturation that happen during adolescence. Those of us who are Sophie Davis alumni know that this is pretty much grilled into you from day one of Sophie Davis, CUNY Med. And it was developed in 1977 by George Engel. And the idea was that we would understand all aspects of life that lead to medical complications for illness as well as for health. So thinking of an example like type 1 diabetes, where a person has not enough insulin being produced by their body and they aren't able to biologically process the sugars that they're having in their main meals. Well, to help mitigate that, we ask folks to take insulin through injections. That requires, if you're thinking about a teenager with diabetes, that they have to stop and plan their meals, or if they're out with friends and they want to have chocolate cake, they've got to go find some place to inject their insulin and then go back to their meal and socializing with their friends. For many adolescents, if they have a little bit of anxiety or if they have other factors at play, they don't want to be different from their peers. And so they're just going to skip their insulin, have the cake, and go on. And that can obviously lead to more biological complications and health issues. Or they may be so fearful of having to separate from the group that they decide that they're not going to go out at all. And they become socially isolated and miss out on some of the key developmental tasks that they should be doing at this phase of life. Adolescent medicine looks at all of this when we're looking at the health issues that bring a patient to our door. Puberty is usually the hallmark of adolescence, and I personally love this slide because it shows how quickly things can change for our young people as they move from this childlike appearance to the adult appearance that they have, but also if we were to look at the images they chose, most of the kids are wearing casual clothing, and then as they become adults, it's more of these sultry looks and this very polished persona that they all have. So toddlers have their temper tantrums, and we expect that, as we said. But when teenagers have their own version of temper tantrums, we as adults get upset. They look like an adult. They should be able to know better and act better. but they often don't. And how we came to understand a little bit about what's going on is from some research that was done in the early 2000s. Actually, it was done way before that, but released in the early 2000s about the secrets of the teen brain. Dr. Jay Geed used MRI and functional MRIs to help us figure out that the human brain continues developing at least until age 25. We also know that the prefrontal cortex of the brain, the executive decision maker, the CEO of the brain, is the part that develops last. I like to sum up this transition as moving from lizard brain, your amygdala and those primitive structures, to the wizard brain, the more cognitive, slow, take your time, weigh your pros and cons part of the brain. There are also some key developmental questions for adolescents. This is more in the social and psychological realm, but biology certainly has an influence. So early adolescence is defined as the tweens, the 10 to 12-year-old age group. And the key developmental question for this age is, am I normal? And if we think about that, going back to perhaps your own adolescence or that of any young people in your life, as your body is changing, there's hair growing in places there wasn't hair before. You smell funny. Everybody looks weird. There's pimples. All of these things are happening. You just don't have the same control over your motor function for a lot of kids. They're very lanky. All of those things make you wonder, am I normal? Am I like everybody else? And this is a main driving force. So when we think about young people with a special health need, to continue the example of diabetes, if they are diagnosed during that time, that's just another something that is making them feel different and not like their peers, and another challenge to their adolescence and their development. Middle adolescence is generally 13 to 15, middle school, early high school age. And the key developmental question of that age is summed up as, am I liked? In this phase, peer relationships are the main driver for lots of the behaviors that young people engage in. This is also when a lot of people will perhaps start smoking or start engaging in other risk behaviors to fit in with a peer group. Looking at that from a positive side, it's also when folks can engage in positive activities that are rewarded by our society, like getting into clubs for their areas of interest. They also might choose activities to be part of a certain group, but also let go of some activities that they were part of just because that was what they felt was expected as part of family life. And this is where we start to see a bit more conflict between parents and children as the young person is figuring out who they are and what their personality is. It's really fascinating for me as a specialist seeing kids, because sometimes you'll see a kid 1 month and they're completely into like preppy type stuff and really focused on school. And then the next time they're into more of like a goth type thing and anime and whatever it might be. So you always have a different personality and they're testing out different things. Late adolescence, 16 on up, the key developmental question is, am I loved? And this is where young people start having more serious romantic relationships, start thinking about their future. Abstract thinking is a little bit more common for this age group. And so they are making future plans about what kind of life they want to have. So as we're talking to young people and getting to know what their drivers are, what their challenges are, I like to keep these questions in mind, because these are the underlying questions of their behavior and their actions. So let's take a moment to talk about transitioning into adulthood. So instead of transitioning from childhood to adolescence, we're moving from adolescence to adulthood. I don't know about you, but adulting can be hard sometimes. I think we've all experienced days where we're like, are you kidding me? I just want to be a kid again and have somebody else handle all of this. I think particularly for this generation, a lot of folks aren't calling people on the phone anymore. So when we have systems set up, like the healthcare system, where you have to call to make an appointment in some cases, or you have to call to deal with the insurance company, that can be overwhelming for a lot of our young people. Paperwork, I think that's everybody's headache. There are a handful of people in the world who enjoy paperwork, and they are great. But for the vast majority of us, we feel overwhelmed with it. And if we don't set up adolescents, particularly those with special health care needs, to deal with some of that, we are doing them a disservice. And most of us have that lizard brain, that toddler brain that's just like, I can't deal with this paperwork. I just would rather eat it or throw it away. So we want to be mindful as we're talking to young people, especially young people with special health care needs, about how they can manage all of this, and that everyone at some point feels a bit frustrated with the tasks of adulting. The vast majority of young people are healthy. 81% of the children in our country would be defined as well children, but we have another 19+% with chronic medical conditions, and that could be a physical ailment or disability, an intellectual disability, or a serious mental illness. For the vast majority of children who are well, the transition process is quite simple. Somewhere around 11 or 12 years old, the pediatrician can bring up the fact that there are some vaccines that we're going to give to help them get set up for adulthood, and that they would continue to be seen in the practice until they're 18, 21, 25, whatever it might be. The American Academy of Pediatrics recommendation is that that conversation happens around 11 or 12 years of age. And for most kids, it's just a one-time thing. We usually encourage pediatricians or other primary care providers to also spend more and more time alone with the adolescent to help them be able to navigate their health concerns and have that discussion one-on-one with their primary care provider. For kids with chronic medical conditions, it can be a little bit more complicated. I see that some of my colleagues who are in pediatrics have joined today, and we've all had the situation where there is a 17-year-old with a chronic medical condition, whether that's diabetes or sickle cell, and they don't know their medications. They don't know the parameters for when they need to call for help. They don't know sometimes even the names of their doctors and why they're seeing them. They just go along. And for those kids, we need a little bit more of a mindful transition. So these are what we call the medically complex kids with frequent hospitalizations. Sometimes they're technology dependent. They might have a tracheostomy tube or use a ventilator. They might be in a wheelchair. There's also a psychological component for these kids. They often have a strong emotional bond to the pediatric team on the inpatient and outpatient side. And quite frankly, as providers, we have a strong bond to these kids as well. We see them grow up. We see them at their most difficult moments, and it is hard sometimes for the providers to let go and help the kid move on. There are also challenges for kids who are socially complex, those who don't have as many resources, whether those are financial resources due to issues related to poverty and or homelessness, minority status, immigrant or refugee status, where they don't have the deep community connections that some other patients and families have. These are what we call the 1%, those who have more challenges and are at higher risk for transition failures. So this article from Lubrona Harris and other leaders in the field of transition care broke down some of the common problems we see when there isn't a mindful transition to adulthood for the medically complex child. There is sometimes a discontinuity of care. They don't know who they're supposed to see for their health condition. Last month, they got a refill of their medications from their pediatric endocrinologist, but they don't have an appointment with their new endocrinologist. And for another 2 months, who's going to do the refill? They might have problems with treatment adherence because of that, not being able to get the medication, not knowing which doctor to listen to if they texted one or sent a patient portal message to their primary care doctor, but the adult doctor is saying something different. We also see excessive morbidity and mortality, so worsening healthcare outcomes for these young people, and preventable emergency department visits as well as hospitalizations. If they don't know who to call at the time of their illness, or if they don't even know how we're monitoring if they're doing well, then they come in crisis mode, and we need to do extra work to get them back on a more stable path. And from the administrative side, there are challenges with increased patient dissatisfaction, increased worry on the part of the patient, as well as the providers and the family, and overall an increased cost of care for the patient, as well as for the medical system and our healthcare system at large. There are things that we can do to help with these processes, and the good folks at Got Transition have outlined a lot of the different steps that we can take. And certainly for pediatric subspecialists, we want to be mindful and really work on this as much as possible, even if that's when the kid is in the hospital. So we'll talk a little bit more about the transition process. Previously, it was more of a transfer as opposed to a transition. So in this cartoon, we have the primary care provider saying, prepare to transfer, and the poor adolescent being launched over to internal medicine. And I haven't decided if this is the front desk person or the parent or a combination of both, but they're like, are you sure? They have that little look of fear as we get ready to launch the kid out to the adult world. So we want to be clear that a transition is not a transfer. It is a mindful process with the goal of ensuring that we have high quality, developmentally appropriate healthcare services available in an uninterrupted manner as the person moves from adolescence to adulthood. Generally, this occurs between ages 18 and 21, but the process should begin at age 12, if not sooner. And I put the little asterisks there as a reminder that the American Academy of Pediatrics is now actually recommending that for some young people, they stay within pediatrics, especially if we think that they are not likely to survive very long with their healthcare conditions. So if their survival is 30, it might be better for the family and the patient for that child to stay within pediatrics. Or if they don't have an adequate system set up to receive on the adult side, then we would keep them in pediatrics a little bit longer. We also want to make sure that the transition process is tailored to the needs of the family and the patient. For some patients and family, there will be something called conservatorship or adult guardianship, where the family continues to have medical decision making. For other families, they are type A personalities. The kid is managing their medical condition better than even the adults are managing their conditions. And that is a very smooth and generally easier transition process, but we have to do the assessments. We have to really meet with the family and the patient where they're at. So this slide, the next two slides I wanted to go through in part because hopefully we have some of the students here or folks who might be considering what their career path is within medicine. For those of us who are in pediatrics, we kind of know this, and as well as our adult medicine colleagues. In pediatrics, our orientation to care, our focus is on growth and development. For adults, it's more the maintenance of well-being as the person ages. In pediatrics, we have a family-centered approach, and we have shared decision-making with the parents. For the adult side, it's patient-centered, and the young adult is the person who is legally in charge of their care. In terms of our practice population, most pediatric patients, like we said, 80% of them don't have chronic medical conditions, whereas in the adult world, the majority of them do. Most pediatric facilities benefit from grants and certain funding. So we have different resources like social workers, therapists, and a multidisciplinary team. Whereas in the adult world, that is not usually available unless you are in a specialty care type setting. Pediatrics, we generally have longer appointments for routine visits, such as preventive care visits, whereas in the adult world, they sometimes have shorter time. In pediatrics, we have part of the visit alone with the patient, AKA child, but in the adult world, they kind of look at you funny if you bring a parent to the visit, especially if you are a little bit older than a typical 18-year-old. And a lot of times, because they are accustomed to speaking with adults, they end up talking to the parent when the parent is in the room, presuming that you brought the child brought that parent there because they want them in charge of their healthcare decisions, because most adults could come to the appointments on their own. So this is something that when I speak with my adult colleagues, I tell them to be mindful of that. Remember who your patient is. Yes, it's more comfortable to talk to the 40-year-old person who's there, but really your patient is that 18-year-old. We also expect in pediatrics that the patient is still learning about self-advocacy. And so we help them speak up and we check in more frequently. On the adult side, it is expected that if you have a concern, you're going to speak up. And so we need to prepare young people for that, especially if they have concerns with anxiety or depression or just are overall non-confrontational. In terms of making appointments and medication refills, the parent or guardian usually handles that. In the adult world, they expect the patient to handle that. I have had some of my adult colleagues say, well, it's usually the lady of the household, the wife of the patient, who handles all of that. That's a whole other topic that I won't get into. In terms of adherence to care, we are generally very, very forgiving. We give reminders and we'll reschedule you and we'll work around your basketball practice that you forgot to tell us about. In the adult world, you show up. If we made an appointment and we didn't send you a reminder and you didn't show up, you might have to pay a no-show fee for that visit. We also have in pediatrics the ability to call Child Protective Services if we feel that the child is not receiving adequate care and not showing up to appointments and being a recipient of medical neglect. In the adult world, that doesn't happen. Certainly, if we have conservatorship, we can use Adult Protective Services, but that is, again, something that you want to plan ahead for. Medication dosage in pediatrics is based on weight. In adults, it's usually one dosing recommendation, and that can be a challenge for some of our patients who have chronic medical problems or are technology dependent and might be a significantly lower weight than what the typical adult provider is used to. In terms of pain medications, we are generally quite liberal with pain medications in pediatrics because we are trying to ease suffering and we don't see as many patients who are addicted to pain medications. On the adult side, it is generally more restrictive in availability. And this becomes a challenge, especially for our patients who have sickle cell disease. Until fairly recently, many people with sickle cell disease were not surviving into their older adult years. As we have improved care in pediatrics, there are many, many more adults with sickle cell. And in some parts of the country, depending on where somebody trained, they might not have ever treated an adult patient with sickle cell disease. And so we need to set up expectations for the patient as well as the providers that they might be seeing that they do need these amount of medications in order to maintain their well-being. And in terms of time and care in the system, in pediatrics, you're seeing a pediatric provider for 10 to 25 years and in that model of care. Adults are going to be in that model of care for 50 or more years. So they will have a transition of different providers at some point. In pediatrics, it's very possible that the child could be seeing their same pediatric hematologist, their same pediatric endocrinologist throughout their whole life. And having those changes and transitions are something that they are probably not used to and is more emotionally involved. So we really need to mindfully think about all of these things as we stay in what I call the transition zone and really work on all of these elements of care. This is a slide from the Texas Health Steps, which is a guide for Medicaid providers within the state of Texas. And I think it really sums up what we do in adolescent medicine and what we're talking about when we talk about transitions. As the child is young, it's a focus on the parent and doctor. Those are the primary people who are talking. In adolescence, we should move towards a parent-patient-doctor relationship and as much as possible involve that young person in their healthcare decision-making. So that by the time they're 18, we have a seamless transition to a patient-doctor relationship where the young person feels empowered to speak to their healthcare providers on their own. So I'll take the last few minutes of this presentation to talk about adolescent medicine, what we are and how we can help. As a field, adolescent medicine is still pretty young. In 1941, the American Academy of Pediatrics had their first medical symposium on adolescence. The first adolescent unit and training program began in the 1950s, the Children's Hospital in Boston. By 1968, the Society for Adolescent Health and Medicine was formed. At that time, it was the Society for Adolescent Medicine, and the idea was that it would be what I call transdisciplinary or metadisciplinary, where the medical providers know some of the psychology and some of the dietary practices, and vice versa, that the dietitians know a little bit more psychology and a little bit more of the medicine than what they typically get in their training, so that we can all keep this biopsychosocial approach in mind. 1987 saw the formation of the International Association for Adolescent Health. And it wasn't until 1994, when I started at Sophie Davis, that the first board certification for adolescent medicine was offered. And I just want to say a little prayer for all of my colleagues who are taking their adolescent medicine boards today. So we have in the US right now about 42 million adolescents. But since 1994, we've had only maybe 900 board certified adolescent medicine specialists, if we add in the handful more that are hopefully passing their boards today. So we are definitely a rare specialty within medicine and a still poorly known specialty. Worldwide, we have 1.2 billion adolescents. That's about the population of some of our most populous countries like India or China. And over 2,000 adolescents die every day, mostly from preventable conditions such as road traffic injuries. In the world, there are still significant problems with diarrhea and tuberculosis as a cause of death for young people. And then interpersonal violence and self-harm are also in the top contributors to adolescent mortality worldwide. For the US, accidents, homicide, and suicide are the top 3 causes of death for adolescents. We also, as you can see from this data, have malignant neoplasms, heart disease, and congenital anomalies as other major contributing causes. For accidents, motor vehicle accidents are still the largest subsection of that group. What we don't know is how much of that is because the adolescent brain is still developing and they're new drivers and taking risks, or how much of that is the young person is driving and engaging in some risk-taking behaviors, maybe drinking and driving and getting into accidents. We also know that adolescent health needs are increasing. Every 2 years, the Youth Risk Behavior Surveillance Study is conducted at representative high schools across the country, and that gives us a snapshot of what's going on with our young people. I call it the tip of the iceberg data. These are kids who are in school. This is not the kids who are in juvenile justice. This is not the kids who are dropped out of school. So whatever we're seeing here is really just the beginnings of what's going on. And we know that we've seen increases from 2009 to 2019, increases in depression and anxiety and increases in suicide plans. This does not include the data from the current COVID-19 pandemic, which is still coming in, but we know that young people have experienced significant anxiety and depression during the pandemic. They are missing a key developmental phase and key developmental tasks. And this is showing up in a variety of ways that have led to pediatricians seeing record number of hospitalizations, a 51% increase in the young women ages 12 to 17 who were reporting suicidal ideation or having attempts. And this is something that led the American Academy of Pediatrics to state that there is a mental health crisis for our young people right now. So the needs are definitely increasing, and there is high demand for our specialty and work in this area. But I don't want to be all doom and gloom. Change is possible. We know that through collaborations with researchers, healthcare professionals, legislators, schools, and community organizations that we can make improvements in adolescent health outcomes. This slide shares some data from the state of Texas, where I was working for the past 9 years, and pop back. 75 per 1,000 women age 15 to 17 in 1988 experienced a pregnancy. And now that number has decreased to 18, and we hope one day it'll be down in single digits, if not zero. And this is a combination of newer technology, but also having folks out there and getting people the level of care they need. This is also in part related to changes in how we teach about puberty and how we teach about the changes that are happening to the body and pregnancy prevention. So those are all of my formal slides for today. For more information, I encourage folks to reach out to me. This is my direct email, drbharriet@gmail.com. I have, as was mentioned, a consulting business where I am more than happy to help pediatricians, primary care doctors, and other healthcare professionals learn more about how they can help the adolescents in their lives and in their practice. And I also have a private practice and am able to see patients in New York, Texas, and Florida. For more information about International Adolescent Health Week, we have lime green, which is the key color of this week to represent their youth and vibrance. And you can click on that website, as well as the International Association for Adolescent Health and the Society for Adolescent Health and Medicine. The Society for Adolescent Health and Medicine also has a Find a Provider tab where you can find a provider in your area. So I'd love to open it up for some more questions during the time that we have left. Any questions, comments?
Can I just talk?
Yes, absolutely.
Okay. I was
Sorry. Hi.
I was speaking with a student, a medical student yesterday who matched to pediatrics, but she's very interested in women's health. And, I mentioned to her, we talked about the idea of her, moving into adolescent medicine for fellowship. But I wonder, is that one of the areas that adolescent medicine physicians are trained?
Yes, absolutely. And many of my colleagues will be at the North American Society for Pediatric and Adolescent Gynecology meeting in a couple of weeks in Chicago. So that might be one that she can see if she can join in as a student member. I'll send you that link a little bit later, but a lot of us are focused on reproductive health and within the Society for Adolescent Health and Medicine, the sexual and reproductive health SIG is one of the large special interest groups that we have. I place implants, IUDs. I don't do major surgery. I leave that to the gynecologists and obstetricians, but
that's sort of basic care and
yeah. Okay. So if someone's really focused on like the primary care aspect of it, I think it's a great fit. And some of my colleagues have also run clinics that focus on bleeding disorders. It's like a whole other subspecialty within adolescent medicine and pediatrics, the young women with like sickle cell or other bleeding disorders, thrombophilias, and how we manage that. Yeah.
Do you feel like, sorry, I'm sure that people have questions.
Okay.
Do you feel as a specialty that it's continuing to develop? It sounds like there's a lot going on.
Absolutely. There is just more and more need. And one of my other hats is that I am an officer with the International Association for Adolescent Health. I'm currently the treasurer. I've done 2 terms as the North American Regional Vice President. And there is just so much more need worldwide. When we think about the rest of the world, 50% of the country population areas are adolescents and people under the age of 25. So there's just going to be more and more need globally. So there's tons of growth. During the pandemic, I actually was one of the few areas where my numbers did not go down, in part because a lot of what I do can be done via telemedicine, but in part because of the need, it was just challenging for all of us, but we have some resilience from our own experiences. The young people, if they don't have that, or if their parents and guardians are no longer available, 140,000 young people in our country lost their primary or secondary caregiver during the pandemic, and they don't have the support that we need during crises like this.
Anybody else have a question? Because I can keep talking.
I can talk about this all day.
Yeah.
Yes.
I'll interrupt you for a minute, Margaret, and then you can ask your question. I probably have a lot of questions, but I just have to tell you.
Proud moment.
This is an emotional moment.
Yes.
Mira, it gives me enormous pleasure to see you and to listen to you. And I knew, for those of you who are here, I've known Mira since she first came to Sophie Davis and watched her graduate and go on to finish her medical degree. And there is nothing better. I mean, it's like being a proud parent, which is a wonderful feeling, but then to be able to come and hear and listen to people who've gone through the program, who make us so proud. But I just love, first of all, I love that you went into adolescent medicine. I think that is delicious, but also hearing what you've done and all the things that you're involved in, and the depth and breadth of what you do, and the impact that you're making in the world and with young people. It's just wonderful. So you are the highlight of my week, my month. It's fantastic.
Thank you, Jean Meyer. It's I'm so glad that you could be here. It's really great just to think about where I was so long ago and where I'm at now. It would not have been possible without Sophie Davis. That I know for sure. When I talk to colleagues, to do a little sidebar, who have either tried to go into medicine or who are currently practicing, the enormous debt and other challenges and the weed out and just who it changed them, how it changed their personality. And I think one of the best things about Sophie Davis is that, it was really non-competitive. When we see other folks in other places, they are just fighting over scraps. And I'm like, oh, we can collaborate here. We don't have to fight over this. My success doesn't mean that I'm taking something away from you. We're all in this together. But we have that because of Sophie Davis. And I love that you provided so many opportunities for students to stay involved and get involved while we were in Sophie Davis. I remember being on the curriculum committee, and and here I am so many years later.
I think you bring up something, and then I let people ask you questions, but it is something about the program and people not feeling like they have to compete, and it's not, you or me, it can be both of us, is something that's often underplayed or forgotten about as such a huge benefit of being in this kind of a program. So it's wonderful.
No, I think it's always been an important part of the culture. I agree.
I think you don't fully realize it until you're out there and you're like, guys, what are you fighting over? Like,
right.
It doesn't have to be this vicious. Yeah.
Right. Also, I'm really glad that we're recording this, because I think we can find a way to, and maybe have you come when we do it or something, but I think it would be great to make this available to more Sophie Davis City College, Sophie Davis current students. It's a difficult time of day for students to be able to come to things, but and there are a number of faculty and staff who are still here, who were here when you were there, who would also, I know, get enormous pleasure from being able to see you and hear you and what you do.
Thank you. Thank you. It would definitely be my pleasure. I know we're planning a What is Hebiatrics session coming up. And just for me as an adolescent medicine specialist, yes, primary care is definitely important, but there are also the young people, what I call adolescent medicine specialty care and hebiatrics. And I really think we need to focus in on that group and their needs, the 20% of young people who have a little bit more challenge to their development. Any other questions or concerns? Yes, Margaret.
I'm just curious. I think I had the same pediatrician till I was probably like early 20s, like at that point in college, so now that adolescent medicine is a growing field, is there a conversation the parents need to have with their children about transitioning them to an adolescent physician? What's the
Yes. No, that's a great question. And I like to tell people adolescent medicine is kind of like neonatology. Not every baby needs to see a neonatologist. Can every baby see a neonatologist? Absolutely. But do they really need to see the well baby that's feeding well, no complications? No, probably not. So some young people can stay with their pediatrician, and that's completely fine. A lot of it depends on the comfort of the pediatrician. There's some pediatricians who are just not comfortable talking about reproductive health or birth control or any psychological issues. And that's the young person that I said, well, maybe you do need to see an adolescent medicine specialist. And it could be a 1 or 2 time visit to just get them on a path to adulthood, or it could be an ongoing relationship. And then they need to see the specialist regularly until they transition to the adult equivalent, whether that's internal medicine or psychiatry. And I think that's the other part of adolescent medicine we don't talk about a lot either, is that I've had several patients where it was a combination. They would have a reproductive health issue, plus a mental health issue, anxiety, depression, eating disorder, what have you, plus other psychosocial risk factors. And instead of them having GYN over here, psychiatry over there, social work over there, adolescent medicine pulls it all in. So they're seeing 1 or 2 people, which is, I think, helpful for patients and families. They're missing less time from work and school, and they're getting everything in one home.
Right, and there's trust there that's been built there over time.
Doctor, when did you see your attention shift toward pediatric medicine? Adolescent medicine?
That's a great question. So I recall, and this I think was in part because Sophie Davis was a commuter school. I happened to be home one morning, and there was one of those morning shows like Good Day New York or something, and there was somebody from Mount Sinai, which is one of the oldest adolescent medicine programs in the country and has a freestanding clinic, and they were talking about adolescent medicine. And I said, this is what I want to do. It's prevention, but it's also specialty. And for adolescent medicine, one can become an adolescent medicine specialist either through pediatrics, family medicine, or internal medicine. And internal medicine is nice, but it definitely wasn't my cup of tea. I really wanted to be the person on the prevention end. And I remember like every patient I interviewed, we would ask them, when did you start smoking? And they would always say like 13, 14, 15. And I'm like, well, somebody should have told you that, 13, 14, 15, we could prevent the COPD instead of having to, deal with it now. And family medicine, I think, held my interest for a while, but I think pediatrics really already has that biopsychosocial model in place, and it really felt like home. And to quote one of my mentors, I went into pediatrics because I like pediatricians, and I like pediatricians. So I actually knew I wanted to do adolescent medicine before I knew I wanted to do pediatrics. So that was the click for me.
That's really great. I want to compliment you too on how you started the talk today, bringing me back to, skateboarding and baseball and the Disney afternoon. It was really great. So thank you for that trip down memory lane too.
My pleasure. Yes. And I want to say hi to Dr. Alexander and Dr. Kaneja, who also joined. I appreciate the support, guys. It's great.
Hey, I'll take 2 seconds to say thank you for an important talk, Vera. Coming from a fellow pediatrician standpoint, from a fellow inpatient pediatrician standpoint, we get to see that spectrum that you talked about earlier, like the kids who are mostly healthy, they've just been used to and having a relationship with their pediatrician. And, usually don't need to come in to see the doctor very often, and they get sick and come into our realm, and, they're meeting that cutoff, they're 17, or then they might be unfortunately 18. And then now even them being admitted to our side of the hospital becomes just a logistics thing, and that's been interesting. And then we get the other spectrum where like you were mentioning in your talk, the chronic kids who we as inpatient doctors have gotten used to and even developed our own relationships with, and who will push to see past 21, 22 a bit. But it was great to kind of hear the recommendation of, as early as 11 and 12 to start having that conversation about, transitioning. I think that's such a great idea. And I'm trying to see ways that, maybe incorporating that into the kids that come in, or, with families that come into the hospital kind of thing.
Yeah, I think.
And then, No, the rest wasn't a question. It was just a shout out to my fellow classmate, and to tell you that she still undermines what she does. She actually was one of the forces out here that started a teen talk clinic. So can you imagine talking about transitional care? Moms who are trying to get through their adolescence and being kind of pushed into adulthood, who also at the same time need care for those babies. And so I just wanted to give an extra shout out.
Yes. Thank you, Shiva. It's definitely challenging on other levels, and I didn't even want to open that can of worms of the double transition that happens as you're trying to complete your own adolescence, plus take care of a child, plus still be, the child in your family. That's at least another hour of talking. Yes. And I think, the hospital, when they're in the hospital, you have a captive audience. So I almost feel like it's actually better to do some of the transition talk in the hospital. But if it comes way out of left field, some parents get really upset about that, and they think they're being kicked out, or some of the teens feel like they're being kicked out. And so definitely being mindful about how that's approached and when that's approached in the hospital is key. I think I saw Dr. pop on. Hopefully she is safe, but if you're in the car again. So I love this little Sophie reunion we've had. Hopefully we'll have an in-person one soon.
That would be nice.
Thank you so much, Dr. Beharry, for joining us today. I really appreciate it. This was a wonderful chat. And coming at this discussion from the lens of a parent, I really appreciated just learning how to start talking to my kids about that transition. So thank you so much today. I mean, are there any other questions? I don't want to cut anybody short here. The Alumni Association will make this recording available on our YouTube page. So please just search on YouTube, Alumni Association of CCNY. And you can learn more about the Alumni Association at ccnyalumni.org. Dr. Beharry, I ask you just to hang on for a quick second while I close up the event. And to the rest of you, thank you so much for joining, and look forward to the next event.
I just want to say to you that I think that this is a great thing to plug for people who are parents, right? A lot of alums who are parents, because as you were taught, well, you obviously have younger kids than I do, but as you were talking, Mira, I kept thinking, oh God, how long did I keep making my kids' doctor's appointment? Probably through college at least, and maybe they could have, should have. So it's interesting.
Yes, the timing of that and tailoring of that is definitely part of the art of medicine. I love. Yes.